Hello, welcome to the HOC Volunteer Feeding Program. My name is Mark Narker, and I am a training specialist with the Hospice of Cincinnati Education and Professional Practice Department. Today I will be discussing the HOC Volunteer Feeding Program. I wanted to thank you so much for your interest in the Volunteer Feeding Program and also your compassionate care and support of our patients. We could not do this without you. So the goal of our program is to provide you with the training which is necessary for the safety of our patients and your safety as well. The Volunteer Feeding Program was developed to help address concerns or questions you may have in regards to feeding patients at Hospice of Cincinnati. In addition, the Volunteer Feeding Program is a Joint Commission requirement. As part of your initial and annual volunteer feeding competency, you will be asked to view this video, bring any questions that you may have in regards to the Volunteer Feeding Program to your Ipcc competency skill check, and speak to the HOC nurse about your questions that you may have. Also, you will attend the Ipcc competency and skill check, which is completed by a HOC nurse as part of your initial training and annual review. This slide is an example of the Volunteer Feeding Ipcc competency skill checklist, which is used by the HOC nurse for initial training and annual review during your competency skill check. So what is the role of the volunteer when feeding our patients at Hospice of Cincinnati? A huge piece of this will be maintaining the patient's dignity, comfort, and safety as you're feeding your patient. Also very important to communicate with our interdisciplinary care team, the nurses, our STNAs, in regards to the patient's feeding needs. We know that our patients do change very often. Also to provide nourishment for our Hospice of Cincinnati patients in the inpatient care center. And we'll also be watching for changes in our patient's ability to eat. So for example, the patient may be having increased difficulty chewing their food or possibly having difficulty swallowing. These changes would be very important to report to the care team. So let's talk a little bit about the swallowing process. So this is a process by which food and liquid is moved from the mouth to the stomach. And actually this entire process of swallowing is very complex. It is regulated by the brain in conjunction with the breathing and also with the automatic reflex of swallowing. In other words, the brain will coordinate this activity so that food or fluid does not accidentally enter into the windpipe or the trachea. So let's talk a little bit about how it does that. There's different phases actually involved in this swallowing process. First phase would be the oral phase. This is where food is chewed, it's mixed with saliva and formed into a ball, which is known as a bolus. So many things have to happen at this point. As we chew our food, it moves to the back of the tongue, and you'll see in this picture that the tongue will actually help to hold the food in place, making sure it doesn't actually fall out of the mouth. And also here at the base of the tongue, we have what's called the soft palate, which is this part right here. It's towards the back of your throat, near the base of the tongue. So you'll notice that it's moved downward. That, along with the tongue, prevents the food from inadvertently falling to the back of the throat, which would cause that person to aspirate either food or fluid potentially into the lungs. The next phase is called the Pharyngeal Phase. This occurs when the patient actually swallows and the food reaches the back of the throat. This is also when the automatic reflex or the swallow reflex is triggered. So many things have to happen at this point as well. One of the things that we'll see happening, looking at the picture here, This is called the soft palate, and one of the things that you'll notice is that the soft palate will move up, blocking any kind of food or fluid from entering the nasal cavity. In addition to that, we have what's called the epiglottis, which is a flap located near the back of the throat. And what it does is it folds over, as you can see here, to block the entrance to the trachea or the windpipe, preventing any kind of food or fluid from accidentally entering the trachea or windpipe, causing aspiration, choking, coughing, possible airway obstruction. One of the things that you also notice that will happen here as the epiglottis moves down, this is actually the food bolus, and it is beginning to descend down into the stomach. The third phase of swallowing is called the esophageal phase, and this is where food actually goes into the stomach. So it makes its way down the esophagus, which is right here. You can see it's a very muscular tube, and there's rhythmic contractions which push the food forward, eventually entering the stomach. So the whole process of swallowing is actually a very complex one, and here at hospice we have patients that experience difficulty with the swallowing process, and we're going to talk a little bit about that now, some of the different diseases that could potentially lead to problems with swallowing. So what can cause potential swallow problems? One of those would be a brain tumor. Patients that have had radiation treatment, especially to the face or to the neck, where it's damaged any kind of the tissue there, could be the esophagus, the back of the throat. Also, our patients that have had severe strokes, which have affected the area of the brain that controls the swallowing process. All of them would experience potential swallowing problems. Also, our patients that have neurological disorders or disease, patients, for example, that have dementia or Alzheimer's, those that have Parkinson's disease, multiple sclerosis, ALS or amyotrophic lateral sclerosis, are patients that have confusion. Also, patients that have a decreased level of alertness or very lethargic, they very frequently will experience problems with swallowing. This is a very important slide. These are patients here at Hospice of Cincinnati that volunteers cannot feed. So there's various reasons why you would not be able to feed your patient. One of those would be if your patient has dysphagia or difficulty in swallowing, which will lead to choking, aspiration. Remember, aspiration is where food or fluid inadvertently falls to the back of the throat, entering the trachea or the windpipe, eventually going into the lungs. Or that patient may have a history of airway obstruction. This is where you have food or any kind of foreign object that would lodge into the trachea or windpipe, preventing the flow of air into the lungs. Another group of patients that we cannot feed would be those that are lethargic or they have that decreased level of consciousness. They experience a high degree of swallowing problems. Also, our patients that are on a specialized diet related to dysphagia. Remember, dysphagia is where the patient experiences choking, aspiration, or they have that history of airway obstruction. So patients that are on a specialized diet related to dysphagia, those would be patients that have a pureed diet, which we'll talk about a little bit later, or thickened fluids. Another group of patients that we could not feed as a volunteer would be patients who are lying back or have a arched or hyperextended neck. And what this does is this opens them up to the potential for aspiration. Remember, aspiration is where food or fluid inadvertently falls into the trachea or windpipe, eventually leading into the lungs. So for those patients, we would not be able to feed them. What are some of the challenges that our patients experience? Let's talk about those, some of the potential causes of these feeding challenges. So we often have patients that are very weak. They may have paralysis on one or both sides of their body. We have patients that experience tremors, which would make it very, very difficult for them to hold any kind of utensils in order to be able to feed themselves. Poor vision, it could be poor hearing as well, unable to receive help as far as commands. Could be lack of coordination. Sometimes we have patients that are able to put food onto a spoon, but then they cannot actually move that to their mouth. We have patients that have memory problems. They may forget how to actually feed themselves, or they may not be able to process your help that you're trying to give to them. We have patients that fatigue very easily. This is not uncommon amongst our patients here at Hospice of Cincinnati. And then also you have terminal illness, which our patients decline gradually at end of life, making it harder and harder for them to eat. Our patients experience a wide variety of feeding challenges, and there's many. So we have patients that have a lot of difficulty opening food containers. Sometimes they're not able to set up the items on a tray. In other words, they could not organize the tray. We have patients that are unable to hold their utensils. We talked a little bit about some of the problems. We have paralysis, weakness. Some patients have a lot of experienced tremors. Some patients are unable to cut up their food or to use condiments. Some patients can put food onto a spoon, but they can't actually get that food to their mouth. There's also that inability to organize their meal or complete eating. We have many patients that experience poor or slow chewing due to weakness and end-of-life illness. Inability to maintain posture also can occur, and this makes it very, very hard for our patients to eat. We'll be discussing this a little bit later in the program today, but when you're feeding a patient or when a patient's feeding themselves, very, very important that their head is upright or tilted slightly forward. We also have patients that have discomfort while they're eating. They have a sore mouth, maybe related to ill-fitting dentures. Maybe they have disease process. Maybe they have open sores within their mouth. Many things happen. Patients that have poor concentration, in other words, they cannot complete a task. They're not able to bring that spoon of food to their mouth. All these represent potential feeding challenges for our patients. These are very important things to know before you actually feed your patient. Does that patient have a food allergy? We have to be very, very careful with that. Some patients can have severe reaction to their food allergies. What is the patient's level of alertness? Remember, we cannot feed patients that have decreased level of alertness, that are very lethargic. They are very, very high risk for aspiration, choking, possible airway obstruction. Does a patient have a history of aspiration? Maybe airway obstruction? Do they choke on food? How much help does that patient require during meals? Some patients are able to feed themselves after you set up the tray. Some patients may need help with only part of the meal. Possibly they need you to cut up the food, or maybe they need help putting the food on the spoon and guiding that spoon to their mouth. Is the patient positioned correctly? Remember, this is really, really important. If the patient is in bed, if they're in a chair or a wheelchair, their head needs to be upright or tilted slightly forward. Can the patient manage finger foods? Finger foods are really, really helpful, especially for patients that are unable to hold utensils. It makes it much, much easier for them to be able to feed themselves. Also helps to maintain that patient's dignity. We always want to offer them that opportunity to do part of their meal, or maybe if they're able to feed themselves completely. And finger foods may be helpful in that. What are the patient's activity limitations? other words, do they fatigue very easily? Are they very weak? Are they able to use maybe their right arm, but they can't use their left arm? All that's important information for us to know when we're feeding our patients when they're setting up their trays as well. Does the patient have dietary restrictions? We'll be talking in a little while about different types of diet. For example, we have some patients that are on soft foods because they have sore mouths and they couldn't chew whole foods such as whole meat or vegetables. What size portions does the patient tolerate? Do they prefer a half teaspoon or less? Very important information to know, and this is why it's vital that we communicate often with our care team, with our nurses, with our STNAs as well. Also, does the patient need dentures? Many times what happens as our patients progress with their disease, they lose a lot of weight and the dentures become ill-fitting and they're actually painful to wear, but in some cases our patients will still be wearing dentures. Is the patient confused? This is also extremely important for us to be aware of, especially when we're feeding our patients. Can the patient use a straw? Patients using a straw will set them up at high risk for aspiration if they have problems with dysphagia. So remember, that would be a history of choking, coughing, aspiration, and airway obstruction. So patients that, for example, that have dementia, Alzheimer's, any kind of neurological conditions such as amyotrophic lateral sclerosis or ALS, patients that have had severe strokes, it impacts their brain and its ability to regulate the swallow process. So if those patients were to use a straw, they would be at extremely high risk for aspiration. More than likely that when they sucked on the straw, that fluid would go right down the back of their throat and into their windpipe or trachea. So we have to be very, very careful before considering the use of a straw. Remember to always check with the nurse and make sure that your patient is able to use a straw before you actually would offer that to them. Has the patient been experiencing symptoms which would limit their ability to eat? That would be their desire to eat and their ability to eat. So keeping the nurses up to date if the patient's experiencing nausea, trouble with breathing, anxiety, pain. All these are symptoms that would impact our patients. It would cause a loss of desire to eat and ability to eat as well. These are some of the different feeding strategies. When we talk about feeding our patients, some of these strategies may be very, very helpful in promoting their well-being during that whole feeding time. So one of those is to look at the location. Really, really important. We want to create that quiet, calm environment. So maybe lower levels on the TV as far as the volume, maybe some calm music. We want to create that calm environment. Not a lot of distractions or stress, which will reduce that patient's ability to eat or their desire to eat. Also, looking at sensory needs. We always want to make sure that the patient has their glasses nearby, hearing aids, and dentures if they're being worn. Also, it may be very beneficial to wake the patient or position him just prior to feeding, because some patients may weaken or tire very, very easily. Some patients may only be able to sit comfortably for short periods of time or tolerate being elevated in bed or maybe in a wheelchair or chair. The other thing that we have to consider as well is many patients may become agitated when seated or elevated in bed. So really, really important that we look at the location and also the sensory needs of our patients. Another helpful tactic that we may use is to provide stimulation before meals. We want to make sure that patients are alert enough to eat. So remember, we can't, as a volunteer, you cannot feed patients that have decreased level of alertness or that are very lethargic because they are at very high risk for aspiration, airway obstruction, choking. One of the things that we can do is to frequently use the patient's name, keep the patient up to date about the time of the day, talk to them about what types of foods are on the meal tray. Also, this is really important as well. We always want to promote that patient's dignity, their comfort as well, but just asking them what kind of food would they like to try first. Dietary textures can be really, really important as well. It can impact that patient's desire or ability to eat. So, for example, patients that have had cancer in the face or the neck and have received radiation treatment, many times that will impact their desire to eat according to the types of food that they're offering. So things like mashed potatoes or bread, for example, may make it very, very difficult for them to eat. These are some of the different dietary types. So we're going to begin by looking at liquids. So we want to include thin liquids. We'll look at that first. Thin liquids are any kind of regular drinks that we may offer to our patients. In other words, they move quickly when poured. So these are things like milk, coffee, water, soft drinks. Thickened liquids include liquids that have been thickened or move more slowly when poured. So let's begin by talking about the medium thickened or nectar thickened liquids. These are fluids or drinks which have the consistency of apricot nectar or V8 juice. As you advance with thickened liquids, you have what's called extra thickened or honey thickened liquids. These are drinks that have the consistency of honey. In other words, when you pour them, they drizzle from the cup. Lastly, you have what's called pudding thickened liquids. And these are liquids that hold their shape even when poured, so they are not pourable, and they do require a spoon in order to consume. Very, very important, if you look at the bottom of this slide, volunteers are not trained to use thicket or feed patients with thickened liquids. Let's talk a little bit about whole foods now. So you have what's called a regular diet, which would be all solid foods, whole foods basically, that require chewing in order to consume them. That would be things like meat, for example, whole meat, whole vegetables or fruits, salad. These are followed if the patient has no health conditions requiring a special diet. However, some patients may require a soft diet. These are foods that are very soft. They're very easy to chew and to swallow as well. This is followed by patients that have problems with possibly poor dentation. They have a sore mouth, which makes it very hard for them to chew whole foods. Also, they're helpful for patients that fatigue very easily while they're chewing or eating, or maybe have trouble with breathing. Lastly, you have what's called a pureed diet, and this includes foods that are mashed and require minimal or no chewing. So these would be things like pureed meat, fruit, vegetables. Typically, a pureed diet is used for patients that are at high risk for aspiration. In other words, these are patients that have a history of dysphagia. Remember, dysphagia is difficulty in swallowing. So part of that would be that risk for aspiration, choking, airway obstruction. So this is their typical use. But they may also be used for patients that have difficulty tolerating a regular or a soft diet, or they fatigue easily with chewing or eating. Let's discuss a little bit about pureed diets. So can volunteers feed? Volunteers may feed patients on a pureed diet if they are on this diet due to inability to tolerate a regular or soft diet because of lack of dentures. Maybe they have a very sore mouth. Maybe that patient fatigues easily with chewing or eating. This is why it's very, very important that we verify with the patient's nurse that this is the reason for the pureed diet. Also, an important reminder, volunteers are not trained or permitted to feed patients with swallowing difficulties. In other words, they have dysphagia. They are at very high risk for aspiration or airway obstruction. So we can never feed a patient a pureed diet that is at high risk for dysphagia. So this is why we always want to communicate with the nurse prior to feeding our patients. Remember, if the patient is on a pureed diet due to inability to tolerate a regular or soft diet because of lack of dentures or sore mouth, or you just fatigue very easily with chewing or eating, you can feed that patient, but you may never feed a patient that's on a pureed diet due to dysphagia. So that's airway, they've had that history of airway obstruction or aspiration. Positioning, as we mentioned a little bit earlier, positioning is really, really important, that we help our patient maintain a proper position during the feeding time while that patient's eating. And that's to maintain their safety, their comfort, their dignity, and also promotes their quality of life as well, which is really, really important for our patients here at Hospice of Cincinnati. You may need to contact the nurse or STNA to properly position the patient. Please keep that in mind. Okay, so as far as positioning, if that patient is in a chair or a wheelchair, very, very important that that patient is seated upright and make sure their body is centered against the back of the chair or the wheelchair. We want to help prevent them from leaning excessively to one side. Also, their pelvis and buttocks and back should touch the back of the chair to prevent the patient from slipping forward. This will relate to their safety. Back should be straight and slightly forward. You should also make sure that the patient's feet are resting on the wheelchair footrest as well. If the patient does have inactive arms due to paralysis, for an example, they should be supported on the wheelchair tray or on a pillow. And also remember, it's vital that the patient's head is positioned upright or flexed slightly forward. This will help to prevent any kind of inadvertent flow of food or fluid into the trachea or windpipe, eventually leading to the lungs. So this is so important to prevent aspiration or that potential risk for airway obstruction. When the patient's in bed, we have to make sure their body is aligned and supported by the surface of the bed. So the position of the head should be at a 75 to 90 degree angle. Remember, the head should always be positioned upright or flexed slightly forward. The chin tilted slightly downward. What this does is it allows gravity to keep the food bolus towards the front of the oral cavity. And what could happen is if the patient's head is tilted slightly backward, this may cause the bolus to slide down the back of the throat before the patient can actually initiate the swallow reflex, causing food or fluid to flow inadvertently into the trachea or windpipe and into the lungs. So you have that high risk of choking or aspiration. This is why it's vital to keep the head positioned upright or flexed slightly forward. Communication, we know, is essential. How many times on a daily basis do you communicate with your patients, with family members, with the members of the care team? So it's important in providing direction and explaining what you're going to do throughout the meal. As volunteers, each and every one of you does such a fantastic job in supporting not only our patients but also family members as well. We know that communication helps to build therapeutic relationships. In other words, relationships built on trust with your patient, which is vital to the care that we're providing for them. So the communication is key when feeding a patient. It helps to promote that patient's safety, comfort, trust as well. So we want to let our patient know what types of foods are available on the tray. We can identify them by name or by taste. Sometimes we'll use what's called the clock method. In other words, this will help to identify the position of the food on the tray. For example, the meat would be at 12 o'clock, or the mashed potatoes is at 6 o'clock. We would use that method to help to allow that patient to know where the location of the food is. Also, we will state the patient's name often, ask them if they need additional help. Volunteers do such a fantastic job at this in assisting our patients. As far as meal tray setup, very important that you place that tray within the patient's visual field, place the tray within the patient's reach, and also if the patient has any kind of weakness on one side of their body, very, very important that we place the food and utensils on the patient's stronger side. Also, patients may need help in cutting up their food into bite-sized pieces, so we'll do that as needed for our patients. They may need assistance also in opening lids or containers. Provide strategies for patients who cannot hold a cup but can easily reach a straw. But again, remember, never use a straw with your patient until you check with the nurse to make sure that that's okay. For patients that have dementia, Alzheimer's, for example, or they have a history of stroke, they should never be using a straw because their swallowing reflex has been interrupted. And when they actually would suck on a straw, they're at very high risk for that fluid to flow inadvertently down the back of their throat, directly into their trachea or windpipe into the lung. Also, to avoid confusion for your patients, really would be helpful to remove any kind of unnecessary items or clutter from the meal tray. As far as feeding assistance, we know that some of our patients may only be able to feed themselves at certain times, or they only require assistance with certain aspects of feeding. For example, they might be able to bring the spoon of food to their mouth, but they can't actually put the food onto the spoon. Some patients are able to move their hand to their mouth, but can't put food on the utensil. So remember, when you're filling the food on a spoon, you want to fill that approximately 1/3 full. It makes it easier for that patient to eat, and hand that to your patient. If your patient can use a cup, for example, hand the cup to them. Hand finger foods to them as well. Finger foods can be very, very well tolerated by our patients, especially those that cannot hold utensils. Sometimes we'll do what's called hand over hand assistance. And what this means is to put your hand over or around the patient's hand to hold the utensil or move the hand to the patient's mouth. Another important aspect of feeding your patient too is to frequently communicate with them. You can maybe gently touch their forearm to help to make sure that they're maintaining their attention and their level of alertness. Remember, you cannot feed patients that have decreased level of alertness or very lethargic. As far as feeding a patient, remember, when we fill the spoon, we want it to be approximately 1/3 full. Very important too, we always want to make sure that the patient's fully swallowed the bite of food before offering another bite. So this is where it's so vital that we look at the patient's throat so you can see the upward and downward movement of the throat as that patient's actually swallowing. In fact, it would be also helpful to allow time for 2 swallows between mouthfuls, as many patients swallow more than once per mouthful. Always important too to go very slowly when feeding our patients. Some of our patients may require more time to actually chew the food and to swallow the food, so if we offer it too quickly, this is where we may interrupt that whole swallow reflex, leading to possibly choking or to aspiration. So we have to be very careful with that. Patients that require spoon feeding also, may require additional time to fully clear the bolus from their mouth and throat. So while you're feeding a patient, these are just some helpful tips. Seat yourself beside and slightly in front of the patient so that good eye contact is established. Make sure the patient's head does not tilt backward. Remember, very important while you're feeding your patient to make sure that patient's head is upright or tilted slightly forward. When the patient's head tilts backward, this puts them at very high risk for choking and or aspiration. So we also watch the up and downward movement of the throat when a patient's swallowing. This will help us to identify when that patient swallowed. Another important point too is remember an empty mouth does not always mean food has been swallowed, as it could be in the back of the tongue or pocketed in the cheek. So very important, some of our patients would potentially pocket food. So we want to observe for that. One of the ways that we can do that is to ask the patient to open their mouth and stick out their tongue. And typically when they pocket food, that's going to be back in their cheeks. So this would be something also, if you notice that your patient's doing that, you'd want to stop feeding and notify the nurse that's caring for that patient. Also extremely important, after the meal is completed, position your patient's head upright for at least 1 hour, and that prevents any reflux of food leading to possible choking and or to aspiration as well. These are some additional tips. So looking at or recognizing requests for more food or indications that the patient is done eating. So sometimes it's a nod, it could be a verbal request, the patient asked for more food, they completed their swallow, or an open mouth. All of these can be potential indicators that a patient would like to continue eating. Remember, it's always important to promote the patient's dignity, and we can do that by asking the patient what they would like to eat next. In other words, offering them choices. Also very important, if your patient appears to be getting tired, if they're maybe nodding off or swallowing is slower, ask them if they're finished eating or if they would like to take a break. So at this time it would be important to allow that patient to take a break and not to resume feeding until the patient is alert enough to eat and would like to continue eating. So as far as feeding safety, these are some really important or key points. Always check your patient's mouth before offering more food. Remember, the patient's mouth must be empty before taking another bite and swallowing. And we know that safe and consistent use of appropriate feeding strategies reduces the patient's risk of aspiration and choking. These are some concerns which we would want to report to the nurse immediately. So the first one we'll discuss is aspiration. This is when food, fluid, or really any foreign object passes into the trachea or windpipe, entering the lungs. So these are some of the signs and symptoms of aspiration. So your patient is coughing or choking during their meals. They are frequently clearing their throat when they're eating or drinking. And sometimes you can actually hear this with your patients when they talk. Their voice will sound very wet, or you may hear gurgling sounds. In addition, the patient may experience a lot of chest congestions around meals. And another feature of aspiration too is that you may see your patient excessively drooling during their meal. Other important concerns to report to the nurse would be any kind of patient complaint of these symptoms, which would impact their ability or desire to eat. So does the patient have pain, anxiety, trouble with breathing, nausea and or vomiting? Nasal regurgitation, or if the food or drink is coming from the nose. Remember, during the normal swallowing reflex, what happens is the soft palate will move upward, prevent any kind of food or drink from entering into the nasal cavity. So what that means is there's some sort of interruption with the swallowing reflex. In other words, there's some problem between the coordination of the brain and the actual swallow reflex. So it'd be very important to report that to the nurse. Any complaint of difficulty swallowing or pain with swallowing, maybe that patient has a extremely sore mouth. Food spilling excessively out of the patient's mouth. Remember, this is an indicator of aspiration especially, and this will occur at around meal time, so we want to watch for that. And also pocketing or holding food in the mouth. And typically when a patient pockets food, remember that will be on the side of the cheeks. All these are really, really important concerns to report to the nurse. So you really want to do that as soon as possible. Okay, another potential problem or concern which we'd want to report to the nurse immediately would be airway obstruction. This occurs when any kind of food or foreign substance actually blocks the trachea or windpipe, preventing the flow of air and oxygen from getting to the lungs. So what do you do? What if your patient chokes while feeding? You'd want to stop feeding your patient immediately. Shout for help as loud as you can. Shout for help for the nurse, the STNA, and press the nurse call light. Keep the patient in an upright position. This will be very important. And also stay with the patient while waiting for help to arrive. Let's talk a little bit now about actual airway obstruction. So what are some of the signs and symptoms of airway obstruction? It would be excessive coughing. That patient will be struggling to get their breath. They're going to be gasping for air. And you'll actually see this on a patient's face. You'll see panic, agitation, anxiety. And remember, the universal sign when a person actually has an airway obstruction, in other words, air cannot enter into the lungs, is to clutch the throat with both hands. That's the universal sign of choking. Another thing that you'll see too is that patient would be unable to speak. You may hear a high-pitched breathing noise, such as wheezing, especially coming from the nose. And eventually, when the person's not able to get air into their lungs, this will lead to unconsciousness. So remember, our focus is always on comfort when caring for our patients. So that would include feeding, and we want to promote a very positive experience for them. So these are some key points when feeding your patient. Always check your patient's position, whether they're in bed, wheelchair, or chair. Remember, you always want your patient's head to be upright or flexed slightly forward. Also, allow your patient plenty of time to chew and swallow their food in between bites. Remember, if the patient's fed too quickly before they completely swallow, this will interrupt the swallow reflex, potentially leading to aspiration or choking or airway obstruction. To promote that patient's dignity, we always offer choices. In other words, what would you like to eat first? Offer food and drink. So remember, we always want to avoid reminders of how little that patient's eating at end of life. Many patients feel very concerned about this. It can create anxiety for them as well. So important pieces, a copy of the diet sheet will be completed by the nurse, so always want to review that with the nurse prior to feeding your patient. We will actually review the sheet and where to document the percentage eaten. Also important information to report to the nurse as well. Did that patient refuse to eat, the percent of meal consumed, and the patient's ability to tolerate eating or feeding. This is an example of the IPCC dietary sheet, and we'll take a look at this. So this is filled out by the nurse prior to feeding your patient. So for example, we have patient Tweety Bird in room 104. Patient's nurse is Mark. They are on a regular diet. and it is okay for them to sit up. But you'll see there that the nurses put their initial, they have swallowing problems. And then if you move over to the column where it says staff feed, the nurse's initial there. So that would mean that patient would have to be fed by one of the staffs. That would be either the STNA or by the nurse. Whereas another example would be the patient Bugs Bunny in room 100. This has been placed in by Nurse Adina, and you'll see their diet is pureed. It is okay for them to sit up, and it is okay for the volunteer to feed. So just to reinforce this, remember you can never feed a patient that's on a pureed or thickened liquid diet if they're on that for reasons of dysphagia, which would mean they have that history of aspiration, airway obstruction, choking. However, if the patient's on a pureed diet because they have a very sore mouth and can't tolerate soft or solid foods, or if they just fatigue very easily, you could still feed that patient, but always check with the nurse first. So this dietary sheet will explain to you, it'll tell you if the volunteer is able to feed or not. You'll have the nurse's initial there, or if it's a staff feed, you'll see the nurse's initial there. So this is a very, very important sheet for you to keep in mind. Also, you'll see there's an area for breakfast, lunch, and dinner, and this is where you would actually record the percentage of food eaten. So just to reinforce this, the nurse will initial if it's okay for them to sit up. Do they have a swallow problem? They would initial here if they did. Do they need their tray set up? It would be initialed here. Is that person a staff feed? In other words, only one of our nurses or STNAs could feed that patient. Then the nurse would initial this column right here. Is that person able to be fed by a volunteer? The nurse would initial right here. Or if the patient's not eating, the nurse would initial right here. This is where you record the percent of food eaten. So for breakfast, lunch, and dinner. Just to kind of wrap things up, we know that when feeding your patient, it allows you to develop a therapeutic relationship with them. It not only promotes comfort, but also quality of life for their patient, which we know is very, very important at end of life. The information that you provide for the patient's nurse, such as the ability to eat or percent eaten, is essential in providing individualized quality care for our patients here at Hospice of Cincinnati. And I can't stress this enough, we so appreciate you being a valuable part of our team and all the compassionate care that you provide every day for our hospice patients. We couldn't do this without our volunteers. So thank you so much. Thank you for your valuable contributions in helping us meet our mission of creating the best possible, most meaningful advanced illness and end-of-life experience for all who need care and support in our community. Thank you so much for your time today. And just remember, if you do have questions after viewing this video, when you do your actual skill check with feeding your patient, if you could please bring those questions to the nurse at the inpatient care center where you're doing your skill check, and they will help to address your concerns or questions that you may have. So thank you so much. Thank you for your time today. And again, thank you for the great care and support that you give to our patients and also family members as well.